for Virgins problems in children. There is a small alteration in the order. Virgins problems in children, and then Virgins problems in presbyopia, and then we go for the muscle balance and eye strain. Yes. Over
Thank
to
you,
Dr.
Madam
Lakshmi.
Laila Madam, for the opportunity, and thank you, AAS. So, Virgins, since refractive error, everything has been discussed in detail. We'll directly go into the Virgins issues. So, every person, or maybe most of the people, have phorias. So, what prevents them from being symptomatic? It is plainly a balance between the demand and the ability. So the ability is the fusional supply or the fusional Virgins ability that a person has, and the phoria at a given working distance is what the patient is having a demand for. So if these two are balanced, then the patient doesn't have a symptom. But if there is an imbalance in these two, this results in an eye strain. So is it really important in children? Because they usually do not give any specific symptoms of Virgins problems. So I would like to classify this into 4 headings, like symptoms. What are the symptoms? How do we diagnose? How do we treat, and how to follow up? So the first thing is symptoms of Virgins disorders. Why is this happening? Because there is a change in visual needs. Because earlier there was a demand for good distance acuity, and now what is happening is there is emphasis on near work, and this leads to a state in which accommodation and Virgins should be sustained without fatigue. So the symptoms and signs are, as everyone knows, blurred vision, headache, motion sickness, ocular discomfort, fatigue, double vision, loss of concentration. So many children may not complain of double vision or strain or headache. They might just have a loss of concentration. They'll read for some time and then stop and go. So if these problems are there, and especially the difficulty there will be in after the 3rd grade, because they'll have all small letters and computer usage. And this eventually results in a drop of performance. So at the earliest of doubt, the ophthalmologist should do a binocular testing or binocular balance testing. And I am just focusing on the Virgins problems. So children with early learning difficulty, they can have Virgins issues more than the regular children, and this may in turn exacerbate their attention deficit behavior. So that should also be taken into consideration, and athletes need a good Virgins and good depth perception for optimal performance. So how do we diagnose, and are there any diagnostic dilemmas? So as I told previously, Virgins and phoria are the 2 limbs, and we have to balance between this. And so the key is we have to check the Virgins and we have to check the phoria. So what is Virgins? It's a disjugate moment, we all know about it, and accommodative Virgins is the majority of the Virgins that we have, and the rest are tonic, fusional and proximal. So the unit of measurement is actually a meter angle, but we usually measure it in prism diopters of how much phoria is there and how much they can fuse. Amount of convergence is measured by this formula. And what is relative convergence? Relative convergence is something which is keeping the accommodation constant. That is, for a given distance, the accommodation is constant, and degree of convergence exerted relative to the accommodation is called a relative convergence. So that is positive when it is increased and negative when decreased. So while checking fusional Virgins, how much should be the fusion to balance the phoria? For this we use the Sheard's criteria, in which the compensating fusional Virgins, for the compensating fusional Virgins should be at least 2 times the phoria. Sorry, it's not phobia, it's phoria. It should be twice. So the blur point is found out, and it should be twice the amount of exophoria to compensate. So if it is not that much, then they'll have symptoms. Diagnostic techniques, first and foremost, as already explained, full plus refraction, measuring the phorias at distance, evaluation of negative and positive fusional Virgins, near point of convergence, Virgins facility, and finally the accommodative convergence ratio, that is AC by A ratio. Because vergence and accommodation are closely interlinked, that many people who have vergence problems will mostly have an accommodative issue along with it. So measuring phoria, there are different methods for it. I'm not going into the details. I'll just brushing through. If we have time in the end, we'll discuss. So prism cover test, that is commonly used. Other methods are the Von Graffi technique and the modified Thornton technique. Von Graffi technique is like this. It can be done on a phoropter or otherwise. And we can test horizontal and vertical deviations by this technique. Modified Thornton technique employs a card in which light is shown through the central dot, and it can be read off from a chart and to find out how much of phoria they have. The next thing is testing the vergence amplitude. So how do we test the vergence amplitude, or how much the patient can converge or diverge? This is tested by two methods. Either it can be a smooth vergence testing, in which we use the phoropter and the Risley prism, and step vergence testing, in which we use the prism bars. So there are 3 points which are taken into consideration: the blur point, which gives the pure fusional vergence; the break point, which gives the fusion plus accommodative vergence; and the recovery, that is the ability to regain binocular vision after the diplopia occurs. So all these 3 things are used. So step vergence is usually advantageous in children because it's difficult to keep them in front of the phoropter. So indirect methods are there by testing the accommodative values that also can give an idea about the vergence. The next things will be a vergence facility testing, which is used during using a flipper, and a 3 prism diopter base in and 12 prism diopter base out prism is used for testing the vergence amplitudes, and it's denoted in cycles per minute. And near point of convergence, as we all know, we use the RAF rule. We can use either a Maddox rod or red-green goggles and light. That is another method. RAF rule, usually we get, the problem is we cannot test very close by because there is the chin rest which obscures that. And break and recovery are noted from the near point of convergence. Jump convergence is another technique in which we use the prism bar, and shift of vergence from distance to near is evaluated. AC by A ratio is the accommodative convergence which is induced per diopter of accommodation, and this is important in patients wearing glasses also. If AC by A ratio is high, then maybe an over minus or an over plus lens might help. So there are different methods for that. This is the normative data and binocular band study which was done in Tamil Nadu. So this gives an idea about the values of near point of convergence, vergence facility, and the vergence amplitude in Indian children. And from this we can see convergence insufficiency is the commonest anomaly in children. Then convergence excess, fusional vergence dysfunction, and heterophoria. So this is a rough guideline of how we can test the convergence issue. Is the phoria greater at distance or near? And we check the AC by A ratio. So by this Duane-White classification, we can classify them into convergence excess, insufficiency, divergence insufficiency, and divergence excess depending upon the AC by A ratio. So symptomatic convergence insufficiency, there is a convergence insufficiency treatment trial which describes a survey which gives the symptomatic score of the patient. Score more than 16 is important. And so neurological diseases are another thing which makes a difficulty in diagnosis, because head injury, degenerative disorders, attention deficit hyperactive disorder, all these things can cause confusion in diagnosis of convergence problems. So convergence excess, in this we'll be having an esophoria more for near, and presents always with an accommodative excess, and so these are the findings in convergence excess. And divergence insufficiency, it is another thing. It shows a low AC by A ratio. These I have shown in that flow chart. It's the same thing. And there is something called a pseudo-convergence insufficiency. The root cause is accommodative insufficiency. The exophoria is more for near, but the alignment improves with a plus lens. Whereas in the normal true convergence insufficiency, the exophoria will worsen with a plus lens. So fusional vergence dysfunction is also another problem which is seen in children. And how do we treat? So I'm not going to the very details of how we treat exactly. I'm just going through the techniques. Optical correction of ametropia in high AC by A ratio patients, we can either give over minus or over plus depending upon the phoria, whether it's esophoria or exophoria. Added lens power, prisms can be given, relieving prisms can be given, and occlusion is another, mainly in cases of anisometropia. Vision therapy and surgery. Uncorrected refractive error, that needs to be taken care of, and while prescribing you have to check about the AC by A ratio. Prisms, we give horizontal relieving prisms based on the Sheard's criteria. Vision therapy, all these accommodation, convergence, everything should be improved with different techniques, and this is the CITT trial which gives a protocol on how we should go along with the treatment and the follow-up of children with all these vergence and accommodative issues. So home-based pencil push-ups, variable trinaglyphs, non-variable hectograms, all these things are office-based and home-based therapy methods for all these vergence disorders. And the previously used techniques are septums, apertures, Brock strings, and all these issues. And I need to put in some word regarding the computer orthoptics random dot stereopsis. We now have the programs like Binox, which can diagnose vergence from accommodative problems, and we can treat that also in the same method. So there are different programs available that is also very effective. Thank you.